Good afternoon, everyone. We're just going to wait a few more minutes for folks to log on. Hopefully there's volume. Yes, you can hear me. Jill's nodding her head. We were just giving it a few minutes for folks to start, but I think given the hour, we will start. Good afternoon, everyone. Hope you guys are getting the opportunity to lunch while you learn. Thank you for joining us. I'm Michelle Schneiderman from the California Healthcare Foundation, and I want to welcome you all to our webinar about medical respite recuperative care. As background, in anticipation of the launch of CalAIM and its historic attention to people experiencing homelessness, we commissioned Arera Health to do a landscape on medical respite care in California. Medical respite is an effective but underappreciated approach to caring for people experiencing homelessness. Today, you'll learn more about the model from a national expert, Julia Dobbins, Director of Medical Respite Care at the National Healthcare for the Homeless Council. You'll hear some high-level findings from Jill Donnelly, Arera's Director of Medicaid Policy and the lead for our soon-to-be-published report. And finally, you'll hear directly from two respite care providers who have incredible expertise and insights about delivering this kind of care. Kelly Bruno, President and CEO of the National Health Foundation in Los Angeles, and Isaias Acosta, Program Director of Hospitality House in Nevada County. Before I hand it over to Julia, I just want to say that this is a topic near and dear to my heart. For 10 years, I had the honor of serving as the medical director of San Francisco's medical respite program and saw firsthand the power of medical respite to improve health and housing outcomes and really radically alter the trajectories of people's lives. So thank you. And here is Julia Dobbins to give us an introduction to medical respite care.
Thank you so much, Michelle. I appreciate it. And what Michelle didn't share is that she also was the recipient of the Willie J. Mackey National Medical Respite Award. So a national respite award focused specifically on people who are making big changes for people experiencing homelessness in the field of medical respite. So her history with respite runs deep. My name is Julia Dobbins. I'm the Director of Medical Respite for the National Healthcare for the Homeless Council. I'm also the Director of Programs and Services for the National Institute for Medical Respite Care, which is an initiative of the Council. I really appreciate spending the afternoon with you guys. Thank you to my friends at Arera for inviting me. And I'm here today to sort of give you a background on medical respite care. Next slide, Jessica. So the reason we're here today is because we know that poor health causes homelessness, that homelessness causes new health problems and exacerbates existing ones, and that the experience of homelessness makes it harder to engage and receive appropriate care. Next slide. And so we've seen how medical respite can address some of those issues. Now, I'm sure that many of you on the call today are very familiar with medical respite care. You might even be running a respite program. But for those of you who are new to respite, we define respite care as post-acute care for people experiencing homelessness. who are too ill or frail to recover from an illness or an injury on the street or in shelter, but who do not require hospital level care. So it's short-term residential care that allows the opportunity to rest, recover, and heal in a safe environment while also accessing clinical care and support services. One theme that you'll see today, I think, in this conversation about respite is that there's a lot of diversity in programming, and that will show up even within the programs across the state of California. Specifically, you'll see diversity in the number of beds, facility type, staffing and services, and even down to admission criteria. Next slide. So I do want to call out that often medical respite care is referred to as recuperative care or vice versa. I want to be clear that we use these terms interchangeably. They do describe the same service. A lot of this is regionalism. To Michelle's point as well, though, in CalAIM's language for in lieu of services, it is referred to as recuperative care, but the National Respite Care Providers Network adopted the term medical respite care. Again, it describes the same service, so you will hear me using it interchangeably. Next slide. So whenever we talk about what medical respite care is, we want to be clear about what medical respite care is not. So specifically, medical respite is not skilled nursing or nursing home or assisted living care. It's also not long-term care or supportive housing. And the reason it's not those services, there's a few reasons for that. First is that medical respite is short-term in nature. It's not part of the model of care that people stay in respite long-term. Additionally, for the vast majority of respite programs, clients are independent in their activities of daily living. Now, I will say there's some gray area in ADLs. There's a difference between somebody struggling to put their shoes on and somebody who's struggling to feed themselves. We are hosting a webinar series this summer, a clinical webinar series on ADLs and respite, and I'll put a link to that in the chat. But these are some of the things that set respite apart. And additionally, we already have skilled nursing and we already have nursing home care, and the purpose of respite is to close the gap in between hospital and these other services and home. Next slide. So while there's a lot of diversity in respite, some of the common themes you'll see as core components of respite are this clinical care piece. So often in respite, people are referred because of an acute issue, and their length of stay is determined by the resolution of that acute issue. But additional to the clinical piece are these other additional potential chronic issues. So people struggling with maybe mental health diagnosis or substance use, all of that falls under the clinical care piece, because in respite, we're providing whole person care. And hand in hand with that is this case management piece. So connecting people to the resources in their community and connecting them with benefits for which they qualify. Also, integration into primary care. So part of the goal of respite is to disrupt the cycle of homelessness. So we want to connect people with a primary healthcare home where they can access primary care and preventive care services. And finally, like I said, respite is a place to rest and recover and heal. So it's really an opportunity for practice, for health education, for goal setting, and really an opportunity to help people become better able to self-manage once they leave the respite program. Next slide. So today we're specifically focusing on programs across the state of California and the diversity of those programs. But to give you a snapshot of what respite looks like nationwide, so more often than not, respite programs are either based in a homeless shelter or in a standalone facility. The median number of respite beds is 17. Again, a lot of diversity there. We see that the average length of stay currently was 28 days, but because of COVID, that has extended a bit. More programs are seeing closer to 40, 45 days. And in terms of staffing, we see a lot of respite programs with social workers, nurses, and community health workers. Next slide. What is treated in respite really depends on your staffing model, and it really depends on the needs of your community. What the literature shows and what we see a lot is issues related to cardiovascular disease, unmanaged diabetes, a lot of post-operative care. This could be an opportunity for somebody who needs surgery but doesn't have a safe place to recover. They can get that surgery. Acute respiratory tract infections, wound care, and seeing a lot more traumatic brain injury, a lot more TBI challenges. Next slide. So we know of about 115 respite programs across the country, with over a dozen, might even be closer to 24 now in development. Respite is really growing. And this probably will come as no surprise to you, but the most respite programs in the country are California-based. 35% of respite programs in this country are programs in California. Next slide. So when we talk about funding respite, this is where conversation can get a little complicated, because the model of respite really combines three pieces that are often funded separately. So respite is room and board, it also is support services, and it's also clinical services. Respite lives right in the center of that. So this can be really challenging for respite programs as they're trying to establish sustainable funding. Most respite programs have multiple sources of funding. And this is changing, though, as more and more states and managed care plans are seeing the benefit of respite programs. Next slide. So in terms of most common funding sources, we see that most respite programs have some type of financial relationship with a referring hospital, which makes sense. But still, a lot of programs are really dependent on private donations and foundation grants. Where we're seeing the most growth, and this is particularly true in California, is with managed care plans. And managed care is seeing the long-term benefit of having access to respite programs for their members. So specifically, California is taking this big step forward for the rest of the country. This is the first state in the country that's going to be offering medical respite recuperative care as an in lieu of service. And in anticipation of that, we are developing some resources for respite programs and healthcare plans related to the models of care, the scope of work, and how hoping to bridge the gap between healthcare plans and respite programs so that they're better able to partner and provide these services for members who desperately need this care. Next slide. So we did a policy brief last year focused on managed care plans partnering with respite programs, and it just highlighted 7 different programs and what that partnership looked like. This is what was covered by the managed care plans. This certainly doesn't cover all of the pieces, but it is a snapshot, and I'll share this resource in the chat as well. Next slide. So what does the literature say about respite? We know that several studies identified decreased readmission rates following a medical respite care stay. We know that individuals discharged to medical respite care were more likely to increase their outpatient service use. That's a good thing. We want people accessing care, outpatient care that they need. And we know that medical respite care results in cost savings for hospitals, even when hospitals fund the medical respite stay. Next slide. The literature also shows that medical respite care was found to improve health-related quality of life and positive impact on health management for people who stayed in a respite program. And we also saw that a connection to primary care provider really had an impact on readmission rates. This data is coming from an updated literature review we published in March, and I will share that in the chat as well. Next slide, Jessica. So we know the advantages of respite. It's safe and cost effective, it improves health, it develops more comprehensive care plan and coordinates care across venues, and it provides time and space for healing and health education. Next slide. But more importantly, we know that it's the right thing to do. Our neighbors without homes are often left to languish in the streets or in shelter when they are hurt or sick, and we have the resources to do better. And it is imperative that we rise to that opportunity. Next slide. So that is the end of, I just did a sprint through what is respite and what does it look like across the country. And now we're going to focus more specifically on California, but please feel free to reach out to me. We would love to talk to you more about this. And thank you again, Aurora. Jill, I'm going to pass it over to you.
Great, thank you, Julia. My name is Jill Donnelly. I'm the Director of Medicaid Policy and Programs at Aurora. And prior to my work here, I worked in managed care for many years. So as Michelle mentioned, we partnered with CHCF to conduct a survey and interview process to get a better sense of medical respite landscape in California. The results of those efforts will be published shortly, but we wanted to provide a preview of some of those, the most intriguing of those results, and also discuss some upcoming policy implications. Next slide. So we started with a survey, reached out to 40 programs, 20 responded. We also, following the survey, realized that there were quite a few commonalities that required further investigation. So we conducted 11 medical respite program interviews to sort of thicken the data, and then 3 other associations that were primarily funders. The topics covered ranged from program models, clinical processes, partnerships, funding, and general challenges. Next slide. So I'm going to go through some of these survey results kind of quickly, but these will all be available in the paper once it's published. So looking first at the types of organizations that identified as medical respite providers, there was a wide range, but mostly what we found out is we did not ask the right categories. So quite a few folks identified as a homeless service organization or a county homeless service, county health department, but many said, we're something else. We're an FQHC, we're a standalone recuperative care program, et cetera. Next slide. The funding sources, so much like the funding data Julia shared, the funding varied widely. Many programs were able to access whole person care dollars if their county or city was operating a whole person care pilot. Others received their primary funding through hospital community benefit dollars. The thing they all had in common, everyone we spoke to said our funding is not stable year to year, and our funding is not a single source. We braid together funding from multiple sources. Next slide. On-site clinical services. So again, almost everyone provides some on-site clinical services. This is in line with sort of the definition of what medical respite is, but the variety of intensity of services and type of services varied widely. Many programs had on-site staff employed directly through the program. Others had staff provided through local hospitals or partnerships with an FQHC, sometimes a co-located FQHC. So you can see that most of them were able to provide medication management, nursing care, disease management, but less standardized were SUD services or behavioral health services. Next slide. Admission criteria was somewhat standardized in terms of everyone accepts folks experiencing homelessness and adults, but there sort of the similarities end. And we found that a lot of the admission criteria was really dependent on what services were available. It makes sense, but it's something to note that there's a wide variety of admission criteria. Next slide. Most programs told us that hospitals were the primary driver of referrals into the program, but programs that have other external partnerships with shelters, with FQHCs, with other homeless service organizations were able to receive referrals through other venues as well. Next slide. So that was a look at some of the data we collected, but we want to tell you a bit more about some of what programs told us throughout the interview process. So what we heard is that there are really common challenges across programs in California. The first is around sustainable funding, which I already mentioned. Funding changes year to year, and the implications on recruiting and retaining staff were huge. This instability made it very challenging to grow in capacity. Many programs told us that coordinating with local partners was often a challenge. They lacked the contractual arrangements or data sharing arrangements to really coordinate care with hospitals, managed care plans, county behavioral health, FQs, and other homeless service providers. Billing seems to be a challenge for many programs. This is a really resource-intensive program, resource-intensive issue, especially for the smaller programs and especially for programs that are working with more than one payer. We'll talk about this a little more in a moment in regards to its CalAIM, but we see this as potentially a growing issue for many programs. Exits to the community. It is a huge challenge to secure permanent supportive housing for all types of providers in California, and medical respite's no exception there. Lack of housing options can often drive up the length of stay for programs that are able to extend lengths of stays. Discharge planning is also a very resource intensive service and requires coordination with a lot of other entities. And while some programs have been able to hire dedicated discharge planners, many have struggled to fund this role. Gaps in the continuum of care. This was something we were somewhat surprised to hear in almost every interview. Programs told us that there was a major need to support clients who are too ill for medical respite, but don't qualify for SNF. So there's a real gap there, one they would like to fill, but requires more staffing, more resources. And many mentioned the desire to offer more palliative and hospice care, but there are challenges around funding those beds. And then finally, access to client data was something that came up over and over. Again, the lack of data sharing arrangements with managed care plans and hospitals made it really challenging for programs to evaluate the effectiveness of their services, although almost all of them are meaningfully trying to find workarounds to that. Next slide. So one of the big things coming down the policy pike that impacts the medical respite field is the in lieu of services, or ILOS initiative under CalAIM. DHCS have approved 14 ILOS, and recuperative care medical respite is one of them. Some of the things to generally know about ILOS is that they are services that are truly offered in lieu of other services, other standard services. They're optional. They're always optional for members, and they are optional for managed care plans. Plans will be able to add new ILOS every 6 months by county. So we've linked to the CalAIM proposal on this slide, and there are a few things to note in terms of the detail around the medical respite ILOS. There's a lot of preliminary information in the proposal, but the community will have more work to do around standardization, around service provision, eligibility criteria, and reporting. Lots of good thinking that's going to be happening there, I think, and is already happening. And finally, the state will be releasing suggested rates for ILOS services, but managed care plans will have flexibility around payment models and reimbursement rates for providers. Next slide. So for the managed care folks on the call, a few considerations worth thinking about. As Julia mentioned, medical respite is seen as a very clearly high value service, improving quality outcomes, decreasing avoidable utilization of inpatient emergency services. And Julia spoke much more eloquently than I can about return on investment, but it is worth noting that in addition to some of the financial ROIs, that there are quality and impacts on reputation and community integration ROIs to be considered as well. As some of our data suggests, there's very high variation among programs, and this really may require some flexibility on the part of plans as they start reaching out and contracting with medical respite programs. Most programs do not have pre-existing relationships with managed care. There were a handful we spoke to that do, but for the most part, these will be new relationships, which may require more supportive onboarding for plans that are contracting with them. And again, this issue around standardization, there is no standard sort of programmatic vetting process in the proposal. Eligibility criteria, there is some, but it's very high level billing or reporting requirements. So a thought that managed care plans may wish to collaborate with each other to standardize some of these asks to minimize the burden on providers, particularly those that are working with multiple managed care plans. Next slide. And a few thoughts for some of the medical respite providers who may be interested in participating in ILOS. This does represent a potential opportunity for more sustainable funding, but it's important to note, as I mentioned earlier, it is optional for managed care plans, so it will be important to reach out to the plans in your county to determine if they're opting in to provide this ILOS. The dollars under ILOS are only available through managed care plans. So this will require a contract either with a managed care plan or a subcontract with an organization that's contracting directly. So, you know, there may be in your community organizations that are going to act as hubs, and that might be a way to participate without directly contracting. And program requirements will vary by managed care plan. It's something to expect and plan for. There is an opportunity here to collaborate with enhanced care management providers. We haven't talked a lot about, talked at all about enhanced care management in this presentation, but this is also part of CalAIM, a major new program coming down the pike. It's a very intensive case management, and this could be a real high value to clients you serve. And again, if you're interested in potentially participating, we really recommend reaching out to the managed care plans in your county. We've linked to a directory that DHCS has published. And for more information on more drilled down provider requirements for participating in ILOS, there's a link as well to the finalized guidance that was published last week by DHCS. So thank you so much for your time. And with that, I'd like to introduce Kelly Bruno.
Thanks, Jill. Super excited to be a part of this and to give everyone on the call a little bit of an overview of National Health Foundation's recuperative care efforts over the past 13 years. So next slide, please. So National Health Foundation runs currently 5 recuperative care programs, 4 of which are permanent sites. So I want to share a little bit with you about each of those sites and a little bit of details on each of those. The first one we'll talk about is our Mid-City location, which is it's been in operation since 2010. It provides 24 recuperative care beds and a motel model. So there's a small picture there of the site. It is we have site control over that motel, and we've been there, like I said, since 2010 and providing 24 beds. This program is a housing for health model, which is Los Angeles County model. So that means that the program is completely funded by Los Angeles County as part of their 600 bed continuum of recuperative care beds. And so our guests that are there are able to stay for upwards of 9 months until they are permanently housed. So some of them stay shorter, some of them stay longer, but they are able to stay and they qualify for the program until they go into some sort of permanent housing. So we have social workers on site, nurses as well, and we have a physician's assistant that's there part-time as well. Our Pico Union facility has been open since November of 2018, and it is a privately funded facility that we renovated back in 2018, about a $1.2 million renovation of a 100-year-old building. The building is in the city of Pico Union. It was built originally to be a sanitarium, if you can believe those words still exist. And we renovated the building to provide 58 recuperative care beds. Actually, it's 61, but because of COVID, we needed to take 2 beds out to accommodate. So currently it's 58 beds. This is a privately funded facility. And so all of the beds that are here are either leased by health plans or by hospitals. That's about 40% of the beds that we have. And the other 60% are utilized by hospitals and health plans on a per diem basis. So the 40% of beds, the lease that we have with health plans is that they prepay for those beds that regardless of census. And so they basically are paying for their capacity. And then our job is to make sure that their beds stay filled. And then the other 60% are per diem beds. And we have an intake department that works with about 50 private hospitals in Los Angeles County to be able to identify guests in their hospitals that are eligible for recuperative care, and then to bring them on into the facility. Because of the payer source, which is primarily hospitals, our average length of stay here is only about 14 days. Hospitals most often want their guests to just remain until whatever medical conditions that are remaining from their acute care hospital stay are resolved, and then we will move them on to the next piece of their continuum, their housing continuum. Ventura County, we have 2 sites. One is actually in the city of Ventura in Ventura County, where we operate 12 beds. We've been open there since 2017. Again, here the average length of stay is about 14 days because we are working always 100% with hospitals here. However, it's funded through a shared cost model. And I usually equivalent this to like a corporate childcare model, where we have 4 private hospitals and then also the public hospital, the Ventura County Hospital, who have each identified the number of those 12 beds that they would like to have at their disposal. And then they prepay for those beds on a quarterly basis. So again, here the payment is predicated on the number of beds that they are reserving versus the actual census. And so we bill them on a quarterly basis. We bill them in advance, and then they prepay for their portion or the number of beds that they are reserving for utilization. We also have a full-time intake person on our staff here as well to oversee those intakes. And then finally in Oxnard, we just opened here this year, and these are 20 beds that are being funded 100% by the County of Ventura. And this is a part of their project Home Key site. So they were able to acquire a Home Key site in Oxnard, and of those 70 beds that are there on site, they have identified or earmarked 20 of those for us, and we are providing recuperative care services there in those 20 beds. Average length of stay here is anywhere between 60 and 90 days, mirroring really the county model in LA that I talked about in Mid-City. So folks are able to stay here until they are permanently housed. We are anticipating that we will be moving into another site in 2 years. The city of Oxnard is really using this as a pilot to understand and be able to prove to the local health plan that recuperative care can sustain itself, and it is actually an economical option for the Medi-Cal health plan there in Oxnard, which just has one. Next slide, please. So most recently, our newest project was that we were actually opened, a project room key in the county of Los Angeles, but we were the only project room key that served as a medical respite or recuperative care program. There were 37 project room keys that opened up in Los Angeles County, and most, if not all of them, had a cohort of folks that were there that had medical conditions or lingering issues that were more than the staff at that project room key could manage. So instead of providing medical services at all of the project room keys, they allowed us to open a recuperative care project room key, and all the folks in those other 37 sites were able to come to us. This was intended to be a 90-day project. We are officially closing the end of this month, which will mark our 13th month. So it stayed open for much longer than what they anticipated. But we were able to open this 90-bed facility in about 3 weeks, stay open for 13 months, and really provide what I feel were much needed services and a really important piece of the project room key service line. Next slide, please. But our most exciting project is yet to come, and we've just been awarded, and we're very excited about. We have just been awarded a 43,000 square foot building in the city of Arleta through the Project Home Key initiative here in Los Angeles. This is a building that was built in 1977 as an assisted living facility. And so National Health Foundation will be able to, once the renovation is complete, will be providing 148 interim housing beds, recuperative care beds for seniors experiencing homelessness. This site will remain as an interim housing site versus the other Home Key sites, which will transition to permanent housing. This one will remain interim and will be open. What they tell us is 30 years. So we'll see, hopefully we'll be able to do that and provide beds specifically for seniors experiencing homelessness. This is absolutely a new space, and we are excited about providing specialized services to the seniors that will be there. The site has, you can imagine, with 43,000 square feet, it has everything your little heart can desire in that space. A beauty parlor, a library, a sun deck. We're anticipating building out a clinic inside, as well as community services as well for the neighborhood overall. Next slide, please. So what's on the horizon for National Health Foundation? One thing is that we have been doing that will continue to be on horizon is the technology and the data that we have that surrounds our programs. So one thing I would say is that we have built our own database and our own mechanism for collecting data on our guests. It also allows us to bill both the health plans and the hospitals, which has definitely been helpful for us. And then also be able to show hospitals and health plans discharge summaries and outcome summaries of what we've been able to do for our guests. Very important to be able to show them the work that they're paying for. The other thing is that we utilize a service, and this is what the picture is that you see there, of something called Pulse for Good. And this is a means by which where we can gather feedback from those that we serve. And so because the folks at our recuperative care sites, at least in the Pico Union one, only stay for about 2 to 3 weeks, utilizing the traditional means of getting guest feedback like resident councils and things of that nature don't necessarily work for us. So Pulse for Good has kiosks, which is what you see here in this picture, where it allows guests to go and touch that keypad and answer 5 quick questions about the site to give us feedback, instant feedback as to how we're doing. The questions, it's kind of similar to those kiosks that you oftentimes will see outside of a restroom at an airport, asking you how clean the restroom is. But the questions are, I feel welcome here. When I'm hungry, I can get food. I've seen my nurse in the last 24 hours, and if you answer yes, was he or she able to meet your needs? I feel accepted here, which is much different than welcome. I've seen my social worker in the last 24 hours. And I think there's a question about if the facility is clean. And then there's a spot at the very end to be able to type in anything you would like us to know. These are anonymous in nature, so we don't know who's writing them. And then the Pulse for Good team gives us reports every quarter on what the feedback we're receiving, so then we can present that to our staff to be able to make changes, and then also to our board to show what our guests think about our services. We're also spending a lot of time preparing for CalAIM, as has been spoken about in this presentation, which means that we're working with our health plans on how to bill, how to do HCPCS billing, excuse me, bringing on medical clinics onto our sites. We have medical clinics that will be coming onto both of our sites because we need to really up our game as far as talking the talk and walking the walk with health plans. So that is a huge emphasis for us right now in preparation this year for that, because that will be the #1 means of reimbursement for us. Excuse me. And that's what this last picture also talks about, is us transitioning to a medical model from a social model. Working with health plans over the last year has shown us that they do indeed speak a different language. But the good news is that they are recognizing that housing is health. And so the CalAIM approval and the 9-month space time that we'll be able to provide medical respite services is very exciting for the future. And so we are spending a lot of time really building the capacity and the infrastructure necessary to shift from that social model to medical model. I agree with what everyone else has said here so far, as this is going to be a huge lift for recuperative care and medical respite sites across California, because quite honestly, most of us don't have the administrative infrastructure necessary to do this. So this is absolutely a focus for us for 2021. And with that, I am going to pass it off to Isaias to talk to us about Hospitality House.
Hello, thank you, Kelly, for that. Appreciate it. And thank you very much to Rare Health Group and everybody on this panel who has been so instrumental in kind of giving us feedback and helping us to kind of improve the services that we provide here at Hospitality House. Isaias Acosta, I'm the program director here. Hospitality House is a homeless service provider in Nevada County in Northern California. And we started out as just an emergency shelter, 69 beds And we were night by night nomadic for many, many years. Our founder was Utah Phillips, and he is a fairly famous folk singer who ended up finding his roots in planting his roots in Nevada County. And he got together with a lot of really concerned citizens from the community and said, you know, this is a resource we need. We need a homeless shelter. There's folks out there, they don't have a place to lay their heads at night. And they don't have food to eat, and we need to be able to provide that. And we can't wait for the state government or the federal government to do it. We just got to fundraise. And so they had concerts and got together and made it happen. And for many, many years, it was operated by volunteers. We went church to church, securing a shelter every night. And after about 7 years of doing that, the church has said, you know, you may want to try and find a building. That would be really helpful for us. So we ended up getting a grant, EAP-CD grant, and I came on about 4.5 years ago. And we bought the building that you guys can see there on that slide. And we started operating full-time out of a centralized location. Again, mostly volunteer run at the time that got it started. But things have changed over the last 4.5 years, 5 years. The landscape of homelessness obviously is changing. They're getting old, folks are getting older. Mental health issues are increasing as people go untreated for long periods of time. And the population is just becoming more challenging to deal with, especially when you consider the model that we've been involved in. So we moved from just having an emergency shelter to really having a robust outreach team and starting to look at that intersectionality of services and the folks too, the demographics. Where's the Venn diagram where everybody overlaps? And it turns out that we serve a lot of different people and have been providing these services for many years, but haven't really codified them and put them into kind of a set program. And so we started looking at some of the healthcare issues that we were dealing with our folks, because a lot of our folks are coming from the hospital, lots of frustrations from the emergency rooms, dealing with some of our folks who are leveraging leveraging the hospital and emergency rooms for really kind of social needs that needed to be taken care of. They're building relationships with the nurses, building relationships with the law enforcement officers who bring them there. And there was just kind of where that was happening. And so we worked with our county and a local hospital to secure some funding for 4 beds initially. And those 4 beds for our recuperative care program had direct referral from the hospital, and we provide kind of intensive case management and sort of 24/7 shelter access, and really working on trying to alleviate those barriers for housing for these folks and focused on the medical side of that. Next slide, please. Next slide, please. However, after doing that for a year or two, we realized there's kind of a greater need. And so we ended up getting a CMSP LICN grant, County Medical Services Program, Local Indigent Care Needs, I believe is what it stands for. And that secured another 10 beds, so for a total of 14 beds in our recuperative care programs. And that was a different sort of referral process. We're working with primary care physicians and folks' medical clinics to get a referral stating, this person could really benefit from some time off of their feet. And the reason we kind of had to make some program changes was our conditional use permit where we're operating, the city requires that folks leave during the day. And so we weren't actually operating 24/7 all the time. And so recuperative care was one of those opportunities for us to really start to, change our program in effective ways and communicate to the city in different ways to really show that, look, there's a need here that we need to be addressing. And, it's larger than just sort of what the concerns are of maybe the local business owners of us operating 24/7. And we have to really start to address these. I think for our recuperative care program over, next slide, please. You can see some of the stats there, the folks that we serve. Again, it's not just an emergency shelter, it's an outreach program as well. So we're going out into the camps and engaging folks where they're at. And 2020 has been a challenging year for a lot of different folks. Certainly for providers, it's been extremely challenging. It's interesting. I know some folks have been working from home and or been out of the workforce for a while, but we ramped up in our service provision and kind of being there on the front lines, dealing with folks where they're at, trying to change programs to increase social distancing and do all of that over the last year. And that's been amazing for us to be able to provide services which historically we maybe wouldn't have thought about, additional transportation, additional food delivery, hotel sheltering, all of these additional things that we've never done before. I think for us, as we look at kind of recuperative care, some of the challenges that we've been having, and again, I'm taking this from a program standpoint, are really kind of twofold. One, obviously, recuperative care is that short-term focus. A lot of the people that we see end up needing long-term solutions to their problems, and they're just going to get worse and worse. Luckily, as a shelter, we have a lot of different dorms, and we have a lot of beds that kind of grow beyond sort of what the recuperative care dormitory can provide. And so we have pathways to kind of move folks on. But I think that's something that, as I see in the horizon, is going to be a great need, sort of hospice level services as we deal with folks at end of life. Because every year we deal with people who pass away in the shelter due to their illnesses, the sickness that they've developed over a lifetime of being on the streets and being marginalized. Additionally, I think with the hospital, one of the challenges that we had initially was, well, what is recuperative care? What is recuperative care? It would have been nice to talk with the hospital a little bit more about that early on, because I think we have talked in this presentation about how there's variation amongst it. And I think even amongst the staff there, the nurses and the social workers who've been amazing, there was always kind of a push to treat us, like a dumping, not a dumping ground, but an alternative to a skilled nursing facility, and maybe expecting some of that level of care, which is something we don't provide currently. But I think that's something certainly we need to look at moving forward as a homeless service provider, because like I said, the folks that we serve are just getting worse off year over year. And there's going to need to be a larger community response to be able to support that. I think if we're talking about the successes for recuperative care in general, and I think just sort of the need of a homeless service provider in the mix here, where maybe historically they've never been, right? Most homeless service providers aren't billing Medi-Cal, don't have the administrative structures to be able to support the requirements that are needed for billing at that level. I think what is happening and what I've seen just in my experience working with these folks is that homelessness is really kind of an issue whose time has come. And I think a lot of people around the country, and certainly here in California, are recognizing that this is not just an issue that the homeless shelters can, bear on their own. They need help and support. And I think some of the other industries, for lack of a better term, hospitals, law enforcement, are dealing with homeless issues and saying, hey, wait a minute, where's the help out there? And I think our biggest success has been in building some partnerships locally, the local law enforcement, local probation, local substance abuse providers, with the hospitals, and saying, hey, we're here as a service. We're here to help. We're here to help do the things that maybe you can't provide. You could take care of their body, some of the medical issues. We're here to kind of take care of some of the community, social, spiritual issues that are going on that are really the missing piece in sort of reclaiming marginalized people. And so in the end, I think what recuperative care has done for us is really allowed us not only to meet our folks where they're at, but allowed us to meet other providers where they're at and deal with their problems and say, hey, homelessness is an issue that everybody's dealing with, and we're here to be your support in that. And I hope moving forward that meetings like this, and as we continue to kind of look at CalAIM and look at some of these other opportunities that are on the horizon for sustainability of some of the programs we're already doing, is just to remember that we are a team and we have to be that way. We didn't know, none of us necessarily picked to work with each other or work together, but everybody who's been at this table has a care for human beings and for the reclamation of those people back into a community of caring. And it's going to take a village to be able to do that. So I really appreciate the time to be able to kind of share a little bit about our programs. Thank you.
Thank you so much. So we have had a few questions come in through the chat, and feel free to keep those coming. I'm going to start with the first one and send it to Kelly. Kelly, the question is, can you address how how any on-site medical services, when available, are provided and what types of personnel provide them, and any information you can provide on how they're reimbursed.
Sure. So indirect medical services, I would say, are provided by nurses. So we have LVNs, RNs on site to provide what we call medical oversight, right? So, and then we also have some of our guests that have skilled needs. And so home health is able to come in and provide that. So if we have wound care issues or somebody's on an IV antibiotic or something of that nature, then home health comes in and we manage and operationalize that process for each guest to make sure that they're getting the maximum benefit. We also partner with a clinic, Eisner Clinic, and Eisner Clinic has brought on site a physician's assistant twice a week for 4 hours, as well as a dental clinic every Friday to provide direct services. And they actually do that through a grant right now. We're in the throes of finalizing a grant to bring a modular clinic actually on site at Pico Union, where we would be able to provide clinic care directly there. All of the other sites, basically for any sort of direct medical care, we have to send them out to either clinics or to their primary care physician. As far as the reimbursement for those medical services, at this point, there is no reimbursement for them. I know the clinic, Eisner Clinic, like I said, they have a grant, but I know in the future, they will be billing for those medical visits when we get that clinic on site. They'll be billing Medi-Cal.
Thanks, Kelly. And a question for Julia. Julia, can you speak to a question about how, if facilities are licensed?
Yeah, this is one of those frequently asked questions that I think I answer on a weekly basis. This is a really challenging issue for respite. There is no licensing category for respite programs. So this is an advocacy issue for every respite program across the country, and it's regional, and sometimes it comes down to county. Many are unlicensed facilities. Some of them are licensed as outpatient care. Some have negotiated a licensing category with their Department of Health. I think it's really clarifying with folks what it is that you're providing on site. To Kelly's point around the reimbursement piece, if a program is partnering with an FQHC, with a health center, they could be licensed. The clinical piece is licensed under the health center's license, and they can bill for a primary care visit if it's within their scope. But yeah, the short answer is there is no specific licensing category for respite programs. I'd be interested, Kelly, how are your programs licensed, or are they licensed? They're just not licensed, right?
Not licensed at all, no.
And that is one of the key pieces about being really, really clear around what the level of care is that you're providing and the scope of care of your program, and making sure that you're not providing a level of care that is bedside care for people who are not independent in their ADLs. This is a safety concern. Yeah.
Great, thank you. And a question for Isaias. How do you handle client needs when it comes to medication management?
Yeah, that's actually a really important piece of it. I think ultimately medications are the focus of the individual who has them. And so we offer lock boxes for each individual to be able to keep their medications near to them. We'll also have a locked room where folks can get access to their medications. We do have some folks who have in-home nursing who come and help them kind of set them up for the week and make sure that they're getting theirs, administering them. But our staff, while we have a nurse as our case manager for our recuperative care program, he doesn't function as a nurse for us in that capacity. He's just kept his license up. He's been a longtime volunteer who's now working for us as a case manager. So we don't want to get into the realm of kind of doling out medications from a staff point.
Great questions. I'm going to throw another one Julia's way. There's a question that came in asking if you know of any medical respite programs that provide services to meet end of life needs, so palliative or hospice care.
Yeah, this is a great question, and to the point that we're seeing our population is aging and a lot more fragile, aging sooner and just generally more fragile. And there is a gap in resources here for a safe and dignified place for people to go at the end of their lives. And so we are seeing more respite programs wanting to expand their resources so that they can be available for hospice and palliative care. And that, I think, is a great partnership for a respite program with the right staffing. One example is Circle the City in Phoenix, Arizona, and they have a partnership with hospice. And so they have a few beds specifically set aside for hospice beds. And hospice comes on site to provide that care. So I think it can be the right venue for it as long as you have the right partnerships and staffing. Again, it changes your staffing model a little bit because for end of life and palliative care, you need to have 24-hour staffing, and not all respite programs have staff on site 24 hours a day. But we are hearing more of it because a lot more of our programs are seeing people come in a lot more fragile, who are closer to end of life than they had seen in the past, and wanting to hold folks during that time instead of discharging them.
Yeah, and I will add, that's something that came up in just so many of our interviews, and that desire to keep folks where they're already comfortable, where they already know the staff was large. So a lot of programs wanted to add that capacity, and we're struggling to do it.
Mm-hmm.
There's a general question around whether there's a list of resources by counties. I'm assuming that's looking for a list of maybe medical respite providers by county. Go ahead.
So I don't have county level resources currently, but I can put a link in the chat, and I have a few other resources I said I would link that I'll do now to our National Directory of Medical Respite Programs, and it will highlight all of the programs across the state of California. And I'd like to also just encourage respite programs. Another thing that we're seeing more of nationally that just makes my heart grow 3 sizes is respite programs coming together in communities to really discuss policy and advocacy challenges. We're seeing respite programs across states do that. And so specifically in Alameda County, they have a respite care providers group that is coming together quarterly to talk about emerging issues and to learn from each other and support each other. And I would just like to encourage every county with respite programs. I know some respite programs are the singular program in their county, but I think that's a really great idea and a really great way to leverage the needs of your program and your community. I'll put a link to the directory in the chat.
Thanks, Julia. And we can send out any links as well after the call.
Perfect.
I'd also note that in the paper that will be coming out from CHCF, there is a list of all the programs that participated in our survey. Not an exhaustive list by any means, but it does include a lot of program detail in case that's useful. Any other questions? Okay, well, we are right at time. So I want to thank everyone who presented today so much for your time and for your expertise and for your heart in this work. And everyone who attended today, thank you so much for your time and for your wonderful questions. Have a great rest of the week. Thank you so much.
Thank you. Take care, everyone.